ఏమైంది? Start. Is it clear? Everything? Welcome back, guys. In this session, let's discuss the most important topics in each system in the physiology. I'll be mainly concentrating on those areas which are having high probability to be asked in the exam. Of course, we have done the rapid revision. So rapid revision is somewhere around 5 hours, right? Now I'll be doing this session for the next 1.5 hours. So in this 1.5 hours, I'll be discussing those areas in physiology which are having high probability to be asked in the exam. For example, in cardiovascular physiology, I'll be discussing 5 topics. Okay. So most of the time, the questions will be asked from these high-yielding topics. Okay. Having said that, without any further delay, let's begin the show. First, look at this question. I'm showing this question. It's a PYQ. Okay. It's a previously asked question. So let's see this. Identify the true statement regarding the point marked. Just look at this image. This is the action potential. Okay, this is the action potential of ventricular myocyte. Just by looking at it, you can say this is the action potential of ventricular myocyte. Okay. Now, you know this marked area. I have marked this area. So what is this marked area? It's a phase 2. Okay, it's a phase 2. So phase 2 is also called as a plateau. Plateau. First, look at this. This is the resting membrane potential. Resting membrane potential of a ventricular myocyte is minus 90 millivolts. Okay. Next, what do we have? We have this phase which is called as the depolarization. Depolarization. Okay. Depolarization due to sodium influx. You know it. Due to sodium influx, depolarization. After that, the phase which I am highlighting here, the phase 2, also called as a plateau. What is the thing that is happening during the phase of plateau? What exactly is happening during the phase of plateau? See, during the phase of plateau, there is influx of calcium into the cell. There is influx of calcium into the cell. At the same time, there is efflux of potassium out of the cell. So there is a balance. The positive ions are going out. At the same time, the positive ions are coming in. So there will be a balance. So that's why the membrane voltage is not fluctuating. It's going to be maintained constant for certain duration. So this phase is called as a plateau. So what is happening during plateau? Calcium comes in, potassium goes out. So the answer is going to be due to slow but prolonged opening of calcium channels. Okay, calcium is coming into the cell. I have told you also potassium is going to go out of the cell. See, what is this phase which I am highlighting right now? This phase which I am highlighting right now is a phase 3, also called as repolarization. Always remember the repolarization is due to potassium efflux. Having said that, I have told you, guys, first thing, the resting membrane potential of the ventricular myocyte is minus 90 millivolts. Okay. Next, there is a phase of a depolarization, phase 0 depolarization due to sodium influx. And next phase called as a plateau. The plateau phase is due to calcium influx and potassium efflux. And last phase is called as a repolarization, which is due to potassium efflux. Okay. Next, the fourth heart sound is caused by the fourth heart sound. See, usually you can't hear the fourth heart sound in a normal person. In a normal person, S3, S4 heart sounds are low pitch heart sounds, which are usually not heard. Okay, they are only heard in some pathological conditions. Now, the point which I am trying to emphasize here is when you will hear the fourth heart sound, in which phase of cardiac cycle? You can't hear it. Usually you can't hear it, but when it will occur, the S4 heart sound is going to be heard whenever there is atrial contraction. In the phase of atrial contraction, there is this S4 heart sound, which you can't hear it until unless the patient is having some abnormality, pathology. Okay. So in the phase of atrial contraction, there is S4 heart sound. Okay. Now you tell me, when the atria is contracting, what is happening in the ventricles down there? When the atria is contracting, ventricles are getting filled with the blood. Okay. Atrial contraction is a time when the ventricles are getting filled. So tell me, the fourth heart sound is caused during the ventricular filling. No doubt in that. Okay, this is the indirect way to ask the question. You know, the fourth heart sound is during atrial atrial contraction. The fourth heart sound is during atrial contraction. But when the atria is contracting, what is going to be happening in the ventricles? Ventricles are getting filled. So, answer. Also, I want you to remember quickly, S1 heart sound is heard during isovolumetric contraction phase. S2 heart sound is heard during the phase of protodiastole. If you don't find the answer protodiastole, you can mark isovolumetric relaxation. S3 heart sound is heard during the phase of rapid ventricular filling. S4 heart sound is heard during atrial contraction. These are the different heart sounds, and these are the phases of the cardiac cycle. S1 isovolumetric contraction, S2 isovolumetric relaxation, S3 rapid ventricular filling, S4 atrial contraction. Okay, so these are the heart sounds and their phases. Next, see this left ventricular pressure volume loop. Okay, the left ventricular pressure volume loop also have a very important, it's all very important for exam, very high yielding topic. Now look at here. In this left ventricular pressure volume loop, okay, the line F2A is representing. Okay, this is what is asked in the exam. Identify the point F2A in the left ventricular pressure volume loop. Even if you don't have any idea about the left ventricular pressure volume loop at this point, you have to know the different phases in this left ventricular pressure volume loop. In this left ventricular pressure volume loop, this down pink color line, which I am going to highlight right now, this pink color line, see this pink color line is representing what? What is the event that is happening during this phase from A to C? From A to C. So this is the phase of ventricular filling. Ventricles are filling. From where to where? Ventricles are filling from 50 ml till 120 ml. Okay, till 120 ml. This is 50 ml is called as the end systolic volume, and 120 ml is called as the end diastolic volume. So what I'm trying to put into your mind is that the down line is representing the ventricular filling. Okay. Next, the point numbers C to D. See here, the pressure is increasing in the ventricle. The pressure is increasing in the ventricle. Okay. So this line is representing isovolumetric contraction phase. The phase from D to E, this phase represents rapid ejection phase. Okay, rapid ejection phase. And phase from E to F represents slow ejection phase. And see here, from F to A, the pressure in the ventricle is decreasing. The pressure in the ventricle is coming down. So what is this phase? This is isovolumetric relaxation. Okay. So what is F to A? F to A, it is like the pressure in the ventricle is decreasing. It indicates isovolumetric relaxation. Isovolumetric relaxation. Ventricular filling, isovolumetric contraction, rapid ejection phase, slow ejection phase, isovolumetric relaxation. So these are the phases of the cardiac cycle, and this is the left ventricular pressure volume loop. Okay. Next, what else you should know in the cardiovascular physiology before going to the exam? The heart sounds and murmurs. Okay, heart sounds and murmurs. See here, the first murmur I am talking about, it's a pan-systolic murmur. Throughout the systole, there is a murmur. Okay, throughout the phase of systole, see the phase between S1 and S2 is called as the systole. So this murmur is a pan-systolic murmur or holosystolic murmur seen in three conditions. One, that is MR, TR, VSD. Mitral regurgitation, tricuspid regurgitation, and ventricular septal defects. Only these three. Mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. These are the three conditions in which the patient is going to have a continuous murmur during the systole. Pan-systolic. That's why pan-systolic throughout the systole. Okay. Next, the second murmur is also a systolic murmur, but the intensity of the murmur is increasing and decreasing. So this is a crescendo-decrescendo murmur. The crescendo-decrescendo murmur is seen in which valvular abnormality and which heart condition? Crescendo-decrescendo murmurs are seen in aortic stenosis, pulmonic stenosis, and hypertrophic obstructive cardiomyopathy. Okay, so this crescendo-decrescendo murmur is seen in pulmonic stenosis, aortic stenosis, or hypertrophic obstructive cardiomyopathy in HOCM. Okay, hypertrophic obstructive cardiomyopathy where there is a subaortic stenosis. In aortic stenosis, in pulmonic stenosis, there is crescendo-decrescendo murmur. Okay, the next murmur which I want you to know for your exam is this diastolic murmur. See this diastolic murmur. Okay, so diastolic murmur. This is the phase of diastole, right? This phase is the diastole. So diastolic murmur, early diastolic murmur. Okay, so it is going to be seen in aortic insufficiency. Aortic insufficiency, the patient who is having aortic regurgitation. Insufficiency means the valve is not closing properly. So aortic regurgitation. in aortic regurgitation, the patient is going to have blowing diastolic murmur. We use the word blowing diastolic murmur, early diastolic murmur. Okay, blowing diastolic murmur or the early diastolic murmur is seen in aortic regurgitation. And last and finally, this murmur which I want you to know, this is a murmur which is there throughout the systole as well as diastole. It's there throughout the systole as well as the diastole. Okay, so this murmur is called as continuous machinery-like murmur. Continuous murmur or machinery-like murmur, also called as a Gibson's murmur. Okay. It is seen in which condition? Patent ductus arteriosus. So tell me, continuous machinery-like murmur is seen with the patent ductus arteriosus. The patent ductus arteriosus can be seen in the babies who are having congenital rubella syndrome, and hypertrophic obstructive cardiomyopathy is going to cause the crescendo murmur or diamond-shaped murmur. Pansystolic murmur is going to be seen with the MR, TR, VSD. Okay, Gibson's murmur is nothing but the Gibson's murmur is nothing but the continuous machinery-like murmur seen in the patent ductus arteriosus. So that's it. Heart, sounds and murmurs. Now, if I ask you, 𝗂𝗄𝗃 murmur, 𝗂𝗄𝗃 murmur. 𝗂𝗃 murmur is seen with, okay, it's also a name murmur. 𝗂𝗃 murmur is seen with acute rheumatic fever. Acute rheumatic fever. Next, Austin-Flint murmur. Austin-Flint murmur. Austin-Flint murmur is seen with aortic regurgitation. Okay, Austin-Flint murmur, aortic regurgitation. 𝗂𝗃 murmur is going to be seen in acute rheumatic fever. These are some important name murmurs which I want you to know. See, if they use a word mid-systolic clicks, I am not using a murmur, mid-systolic clicks. Mid-systolic clicks are seen with, very important for your exam. Mid-systolic clicks are going to be seen in, look, mid-systolic clicks are seen with mitral valve prolapse, MVP, mitral valve prolapse. In mitral valve prolapse, yes, of course, mid-systolic clicks are there. Also remember, there will be late systolic murmur. Late systolic murmur. The patient who is having mitral valve prolapse, usually mitral valve prolapse is going to be seen because of the cystic degeneration of the mitral valve. Okay, cystic degeneration of the mitral valve is usually seen with the Marfan syndrome, connective tissue disorder, fibrillin 1 gene defect. Okay, so at the end of the day, the patient is having mitral valve prolapse. This mitral valve prolapse is going to cause the mid-systolic clicks and late systolic murmur. Just now, I have discussed blowing diastolic murmur. I have told you just now, blowing diastolic murmur is seen with aortic regurgitation. Aortic regurgitation. So in aortic regurgitation, the patient is going to have bounding pulse, Fournigan's pulse, water hammer's pulse, head bobbing. Okay, all these things will be seen with the aortic regurgitation. Whenever you see the word opening snap, okay, diastolic rumble with the opening snap. The moment you see this word opening snap, you have to think about the patient is having mitral stenosis. Mitral stenosis. So mitral stenosis is going to have, the patient is going to have the loud opening snaps. So with this, the heart sounds and murmurs are completed. The next most anticipated area in your exam is the jugular venous pressures. Okay, the pressure changes in your internal jugular vein. Okay. Now, in the internal jugular vein, sometimes the pressure is going to increase and sometimes the pressure is going to decrease. Sometimes the pressure increases, sometimes the pressure decreases. So these pressure changes are noted here. See, A wave, the pressure is increasing. A wave, X wave, the pressure is decreasing. V wave, the pressure is increasing. Y wave, the pressure is decreasing. So when you will have this A, C, X, V, Y waves, the A wave is during the A wave, when you will have the rise in the pressure in the internal jugular vein, the A wave, during atrial contraction. Atrial contraction. The small C wave, which is very important for your exam, C wave is seen during the phase of isovolumetric contraction. Sorry, not isovolumetric contraction, sorry. Of course, it's isovolumetric contraction, but the better answer is going to be the C wave, which is very important for your exam. C wave is seen during the ventricular contraction leading to bulging of tricuspid valve into right atria. So this is the event. when the right ventricle is contracting, especially isovolumetric contraction, when the right ventricle is contracting, that's going to cause the bulging of the tricuspid valve into the right atria, that increases the pressure in the internal jugular vein. Okay, that's why there is a small wave which is called as the C wave. So C wave for contraction, ventricular contraction leading to the bulging of the tricuspid valve. The X wave, see X wave here, it's a negative wave. The pressure is decreasing. So when you will have the X wave, okay, during atrial relaxation, the X wave is seen during atrial relaxation. The V wave, see again the pressure is increasing. When the pressure in the internal jugular vein is going to increase, the V wave is seen during the phase of V for venous filling of the atria. Okay, venous filling. Venous filling of atria. When the atria is filling with the venous blood, especially when the right atria is getting filled with the venous blood, so automatically the pressure in the internal jugular vein also increases. So V wave is seen during the venous filling of the atria. And the Y wave, Y for 𝗵𝗵𝗆𝗃. 𝗵𝗵𝗆𝗃. What is that Y? Y wave is seen during atrial emptying, during the phase of atrial emptying. So in your internal jugular vein, sometimes the pressure is going to increase and sometimes the pressure is going to decrease. They are represented as ACXVY waves. A wave is seen during atrial contraction. C wave is going to be seen during the bulging of the tricuspid valve into the right atrial cavity, and V wave is going to be seen during the venous filling of the atria. Y wave is going to be seen during the atrial emptying into the ventricles. Okay, these are the different JVP waves. Now, in certain disorders, there will be abnormal JVP findings. Okay, abnormal JVP findings. See, in which condition the A waves in the jugular venous pressures is going to be absent. The A wave in the JVP is absent. It's going to be seen in the atrial fibrillation. In a condition called as the atrial fibrillation, the A waves are going to be absent. Large A waves. Guys, large A waves are going to be seen in which condition? Large A waves are seen in conditions like tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension. In these conditions, okay, large A waves are going to be seen in, especially the answer that's many times asked in the exam is the tricuspid stenosis. In tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, the patient is going to have the large A waves. Cannon A waves. Cannon A waves are also called as the giant A waves. Okay, cannon A waves are giant A waves. They are going to be seen in conditions wherever there is atrioventricular dissociation. Atrioventricular dissociation. In which conditions the patient is going to have atrioventricular dissociation? In from medicine, atrioventricular dissociation is going to be seen with third-degree heart block, also called as complete heart block. Junctional tachycardia. Okay, junctional tachycardia. Okay, the patient is having just normal ventricular tachycardia. Okay, ventricular tachycardia, junctional tachycardia, or third-degree heart block. In all these conditions, the patient is going to have the atrioventricular dissociation. Whenever the patient is having atrioventricular dissociation, the patient is going to have giant A waves or cannon A waves. Okay. Now say tall V waves, blunted X, prominent Y. See these three findings. Okay, these three findings are going to be seen in one condition. That is a tricuspid regurgitation. So there is a condition called as a tricuspid regurgitation. In this condition, the patient is going to have three JVP findings. That is blunted X, prominent Y, and tall V waves. Tall V waves. Okay. Not only that, here the point is this prominent Y. This prominent Y. Yes, it is seen in tricuspid regurgitation. There is no doubt. But prominent Y is also seen in one more condition. What is that? It is constrictive pericarditis. There is a condition called as a constrictive pericarditis. In constrictive pericarditis, a patient is going to have both the prominent X and prominent Y. So both the prominent X descent and prominent Y descent are going to be seen in which condition? Constrictive pericarditis. Constrictive pericarditis. Okay. Now comes the question. This prominent X descent. Okay. This prominent X descent. Okay. Is also going to be, yes, it is seen in constrictive pericarditis. No doubt. Prominent X is going to be seen with the constrictive pericarditis. But this prominent X descent is also seen with one more condition. What is that? The prominent X is also seen with cardiac tamponade. So there is a condition called as a cardiac tamponade. In cardiac tamponade, the patient is going to have prominent X, blunted Y. So let me write clearly. So in cardiac tamponade, what 𝗵𝗵 findings are going to be seen? The 𝗵𝗵 findings are going to be in cardiac tamponade, prominent X, blunted Y. Prominent X, blunted Y. In constrictive pericarditis, both prominent X, prominent Y. In tricuspid regurgitation, the patient is going to have 3 𝗵𝗵 changes. One is the 𝗲𝗵 wave, blunted X, prominent Y. So these are the 𝗵𝗵 abnormalities that I want you to know for your exam. If you know this, definitely there is a chance that one question will be coming from this slide for sure. Okay. If you want to know one more thing, a patient with tricuspid stenosis. In tricuspid stenosis, yes, of course, the patient is going to have large A waves. Tricuspid stenosis, large A waves are going to be seen. But the patient with the tricuspid stenosis is also going to have blunted Y descent. Blunted Y descent is also going to be seen with tricuspid stenosis. Yes, of course, in cardiac tamponade it is seen, also seen with the tricuspid stenosis. Next most important area which you should know for your exam in the cardiovascular physiology is the cardiac reflexes. There are different reflexes. First reflex is the Cushing's reflex. What is Cushing's reflex? Cushing's reflex is a condition where increase in the intracranial pressure, any condition which is causing the intracranial pressure, increase in the intracranial pressure, in that person the heart rate is going to be less. So this is called as the Cushing reflex. Increase in the intracranial pressure leading to the bradycardia. This is called as the Cushing reflex. Maybe the patient is having some hematoma. Maybe the patient is having some tumor. So increase intracranial pressure, decreasing the heart rate. Next, what is �𝗏𝗃 reflex? What is �𝗏𝗃 reflex? �𝗏𝗃 reflex means if you put certain chemicals into the, if you keep certain chemicals into the bloodstream, into the cardiovascular system, like serotonin, veratridin, capsaicin. Okay, so veratridin, serotonin, capsaicin, if you introduce these chemicals into the cardiovascular system, there are certain chemoreceptors present which will ultimately at the end of the day decreasing the heart rate. Because of these chemicals, these are cardiac irritants. Because of these chemicals, the heart rate is going to decrease. This is called the �𝗏𝗃 reflex. �𝗏𝗃 reflex. Not only heart rate is going to decrease, the patient is going to have low BP, the BP is going to decrease, hypotension is going to be there, also apnea. The patient is going to develop the apnea also. So these changes are going to be the same. This is �𝗏𝗃 reflex. So tell me, both in Cushing's reflex, heart rate is going to be decreased. In �𝗏𝗃 reflex, heart rate is going to be decreased. So both are bradycardic reflexes. The only reflex where the heart rate is going to increase is the Bainbridge reflex. In Bainbridge reflex, what exactly happens is if you increase the venous return to the heart, maybe you are increasing the blood volume, so more venous return. If you increase the venous return to the heart, or they can say if you cause the atrial distension, okay, if you cause the atrial distension, okay, atrial distension, so that's going to increase the heart rate. Okay, so whenever the venous return to the heart is increased, or the atrial distension is going to be there, saline infusion, if you infuse the saline, the venous return to the heart is going to be more, the venous return to the heart is going to be more, the volume sensing receptors in the heart is going to be activated. So finally at the end of the day, the heart rate is going to increase. So tell me, which reflex is the tachycardiac reflex? The Bainbridge reflex. Bainbridge reflex is a tachycardiac reflex. Okay, that I want you to know. Next, what is this baroreceptor reflex? In baroreceptor reflex is the stimulation of the baroreceptors. Okay, the stimulation of the baroreceptors. Where do baroreceptors present? The baroreceptors are present in the aortic arch. Okay, in the aortic arch, there are baroreceptors present. Also in the carotid sinus. Okay, after the carotid sinus. In these areas, there is a aortic baroreceptors present. There are carotid baroreceptors present. If you stimulate these baroreceptors, what happens? The heart rate is going to decrease. The stimulation of the baroreceptors, the activation of the baroreceptors is going to cause a decrease in the heart rate. This is the baroreceptor reflex. So I want you to know these reflexes for your exam. Cushing reflex, increase in the intracranial pressure, decrease the heart rate. �𝗏𝗃 reflex, certain cardiac irritants like serotonin, veratridin, capsaicin, they are going to decrease the heart rate. What is Bainbridge reflex? Increase in the venous return to the heart. More the blood coming to the heart rate will be more. The heart rate increases. That is Bainbridge reflex. And what is the baroreceptor reflex? The activation of the baroreceptors in the aortic arch and the carotid sinus is going to cause the reflex, the decrease in the heart rate. That is called the baroreceptor reflex. Okay. Now, after these reflexes, I want you to know a few more important points. What is Frank-Starling's law? Frank-Starling's law. The Frank-Starling's law tell you the more the blood you keep into the heart, the more the ejection will be. The more the blood you keep into the heart will pump more blood. So that is end diastolic volume. End diastolic volume means the blood that you will put into the heart. End diastolic volume is the directly proportional to stroke volume, the blood that will come out of the heart. The more you increase the end diastolic volume, the more will be the stroke volume. Okay, or you can say more the preload. End diastolic volume is nothing but the preload. We call it as a preload. The more the That is called as lactogenesis. Okay, lactogenesis. Lactogenesis is because of prolactin. Lactogenesis. Once the milk is produced, it need to be ejected. Okay, it should need to be ejected. That is galactokinesis. Galactokinesis or milk ejection. The galactokinesis is because of oxytocin. Okay, oxytocin. Okay, so mammogenesis is because of estrogens, lactogenesis is because of prolactin, and galactokinesis is because of oxytocin. There is one more Hello guys, hope everything is clear now. I hope you can hear me. There is some audio glitch. So let's continue with our topic. So we are discussing that what are the stimulus for the antidiuretic hormone. The stimulus for the antidiuretic hormone is the hypertonic plasma. But when they ask you about what is the major stimulus for the aldosterone, the major stimulus for the aldosterone, most of the students will think it is hypotension. No, it's not the hypotension, it's the hyperkalemia. Whenever the body potassium levels increases, hyperkalemia means more than 5.5 milliequivalents per liter. Whenever you are having this much amount of potassium, more than 5.5 millimole per liter or milliequivalents per liter, if you have that much amount of potassium, that's called as a hyperkalemia, and hyperkalemia is a major stimulus for the release of aldosterone. And regarding aldosterone, I want you to know one more point. Aldosterone, it's a steroid. It's a steroid, right? So as it's a steroid, it is having which receptors? Cell surface receptors or intracellular receptors? It's having intracytoplasmic receptor, because steroids cross the cell membrane. Steroids cross the cell membrane, right? So aldosterone is having intracellular receptor, or you can say intracytoplasmic receptor. Okay. Next, a cell shown in this image secrete which are the following hormone. So this cell which I am highlighting right now here. So there is this cell which I am highlighting. So this cell is going to secrete which hormone? Just by looking at this histology, you should be able to tell that this is the histology of the thyroid gland. In the thyroid gland, these are the numerous follicles which you can see. All these follicles are the places where T3 and T4 are produced and stored. But what are these cells? These cells which I am highlighting, they are in between the follicles. They are called as the parafollicular cells of thyroid gland. So what exactly are they? They are parafollicular cells. Now these parafollicular cells, what do they secrete? What do you think they will secrete? Calcitonin. They will secrete calcitonin. Can you tell me what is the function of calcitonin? The function of calcitonin is to decrease the blood calcium levels. Then who increases the blood calcium levels? The blood calcium levels are increased by parathyroid hormone, also vitamin D. So vitamin D increases the blood calcium levels? True. Parathyroid hormone increases the blood calcium levels? True. Then who decreases the blood calcium levels is calcitonin. Calcitonin decreases the blood calcium levels. I want you to know one more thing. Parathyroid hormone, yes, it increases the blood calcium levels, no doubt in that. But it decreases the phosphate levels in the blood. Parathyroid hormone decreases the phosphate but increases the calcium. But vitamin D, it increases the calcium, also increases the phosphate. Calcitonin doesn't have any role on the phosphates. It doesn't have any role on the phosphates. But parathyroid hormone, vitamin D, both increases the calcium. But parathyroid hormone decreases the phosphates, and vitamin D increases the phosphates. These are the points which I want you to know. Next, thyroxine. The moment you see the word thyroxine, immediately what should come into your mind? It's a T4, thyroid hormone. T4, thyroxine. Okay. It's having maximum affinity for the which are the following. So T4, you know, it's going to have a long half-life. T4 have a half-life of almost 7 days. T3 have a half-life of just 1 day. Okay. So T4, what it is going to do? it is going to act on the tyrosine kinase receptors. So insulin mainly acts on adipocytes, skeletal muscles. Okay, it acts on the adipocytes and skeletal muscles, helps in the production of glucose transporter type 4, with which the cells can uptake the glucose, absorb the glucose. So what I'm trying to put into your mind is insulin is going to act on which cells? Adipocytes and skeletal muscles. When it is acting on the adipocytes and skeletal muscles, now these tissues are going to produce the glucose transporter type 4, which is going to help in the absorption of glucose. Next, prothrombin to thrombin conversion. You know, prothrombin is factor number 2, inactive factor number 2. Prothrombin to thrombin conversion need which of the following? Here the concept is they're asking for the conversion of an inactive factor into active factor. Okay, to convert an inactive factor into an active factor, what is required? So look at this diagram. Prothrombin to thrombin. For the conversion of prothrombin to thrombin, you require calcium. Okay, you require calcium. Of course, other things are needed. Phospholipids are needed. Like, you know, factor 5A, factor 10A are needed, but they are not that important. Mainly, it's the calcium for the activation of clotting factors everywhere. See, for the activation of clotting factors, you require calcium, phospholipids. Okay, the two most important things which are needed are calcium and phospholipid bilayer. Okay, they are needed. Okay, the answer is going to be calcium. And also remember, calcium has a very important role in the exocytosis of the vesicles. In the process of exocytosis, of the substances, which ions are required? Calcium ions are required. Okay. Next, vitamin K, what it will do to the clotting factors? We all know, we have studied vitamin K have some role in clotting. What it will do? Vitamin K causes the gamma carboxylation of factors number 2, 7, 9, 10. These factors, for their activation, they require a process called as the gamma carboxylation. And who is going to do the gamma carboxylation? That gamma carboxylation is done with the help of a vitamin K, reduced form of vitamin K. Okay, to be precise, it's a reduced form of vitamin K which is required for the process of gamma carboxylation of factor number 2, 7, 9, 10. Okay, which of the following hormones regulate the blood levels of vitamin D? You already know vitamin D, what it's going to do? It's going to increase the calcium, also going to increase the phosphates. But who is going to regulate the vitamin D levels in the blood? It's a parathyroid hormone. So parathyroid hormone, it's going to activate an enzyme called as alpha-1 hydroxylase. Okay, parathyroid hormone activates the alpha-1 hydroxylase. So once the alpha-1 hydroxylase is activated, it converts inactive vitamin D. Okay, so this parathyroid hormone, what it is doing? It is going to stimulate the enzyme called as alpha-1 hydroxylase. This alpha-1 hydroxylase converts inactive vitamin D into active vitamin D in the proximal convoluted tubule of the nephron. Okay, adrenal medulla. You know, adrenal gland, it have adrenal cortex and adrenal medulla. In the adrenal medulla, there are cells called as the chromaffin cells. Okay, chromaffin cells. These chromaffin cells are going to release what? These chromaffin cells are going to release epinephrine, norepinephrine, or you can say adrenaline, noradrenaline. They are nothing but the catecholamines. So catecholamines are coming from the adrenal medulla. Okay. Epinephrine is the catecholamine, also called as the adrenaline. Okay. Aldosterone, it is coming from the zona glomerulosa of the adrenal cortex. Cortisol is coming from the zona fasciculata of adrenal cortex. Sex hormones are coming from the zona reticularis of adrenal cortex. You know, adrenal cortex is having 3 zones: zona glomerulosa, zona fasciculata, zona reticularis. Okay, so sex hormones. Which sex hormones are coming from the zona reticularis? That is dihydroepiandrosterone sulfate. Okay, very important thing which was asked in FMGE exam. DHEAS is exclusively produced from adrenal gland, adrenal cortex, zona reticularis. Next, ILGF1. ILGF1 means insulin-like growth factor 1, which is also called as a somatomedian C. is produced by which of the following organ? Who produces this somatomedian say? See, growth hormone, when it acts on the liver, growth hormone receptors are present on the liver. Growth hormone, when it acts on the liver, liver is going to release insulin-like growth factor 1, also called as somatomedian say. It gives the negative feedback to the growth hormone. Okay, ILGF1, insulin-like growth factor 1, it gives the negative feedback to the growth hormone. With that, important topics in the endocrine physiology are completed. Next, let's see some important topics in the respiratory physiology. In the respiratory physiology, say the most important area is the surfactant. Surfactant. Okay. So RDS, what is RDS, guys? Respiratory distress syndrome. Respiratory distress syndrome is due to deficiency of, tell me. Respiratory distress syndrome is due to deficiency of surfactant. Surfactant. Can you tell me what exactly is a surfactant? Surfactant is a lipoprotein. It's a lipoprotein. So what is the major lipid? What is the major lipid in the surfactant? Okay, 90% of the surfactant is lipid. What is the major lipid in the surfactant? The major lipid in the surfactant is called as dipalmitoyl phosphatidylcholine, DPPC. Dipalmitoyl phosphatidylcholine, also called as lecithin. Okay, dipalmitoyl phosphatidylcholine, also called as lecithin. So respiratory distress syndrome is due to deficiency of surfactant. That's the best answer. Or you can also say the respiratory distress syndrome is due to deficiency of the lecithin. Okay, lecithin is nothing but the surfactant. Okay, the major lipid is lecithin. There is also minor lipid. There is also minor lipid that is called as sphingomyelin. Sphingomyelin. Okay, sphingomyelin. So respiratory distress syndrome, also called as a hyaline membrane disease. Okay, respiratory distress syndrome, also called as a hyaline membrane disease, is due to deficiency of surfactant. Sometimes they can also ask you, respiratory distress syndrome in a neonate can be due to which hormone? It can be due to excess of which hormone? Which hormone can lead to respiratory distress syndrome or hyaline membrane disease? Insulin. Insulin. Why insulin? Insulin decreases surfactant. Insulin decreases surfactant. Decrease in the surfactant, when the surfactant is not there, that's going to cause respiratory distress syndrome. That's going to cause the respiratory distress syndrome. Okay. Then who increases the surfactant? Insulin is going to decrease the surfactant. Okay. Then who increases the level of surfactant? Who increases the surfactant? Let me write here. It is steroids. Okay, steroids, especially cortisol. Steroids are glucocorticoids, or you can say steroids. They are going to increase the surfactant. Steroids increases the surfactant. Then who decreases the surfactant? Insulin decreases the surfactant. Okay. Next. Look at this question. Adequate amount of oxygen delivery to the tissues occurs in which type of hypoxia? See, oxygen is going to the tissues. In this question, they are saying oxygen is going to the tissues, but the tissues are unable to use the oxygen. Okay. So in which type of hypoxia? See, 𝗵𝗵𝗃 hypoxia means outside oxygen is not there, so you are not getting the oxygen. 𝗵𝗵𝗃 hypoxia. 𝗵𝗵𝗃 hypoxia, it is seen in high altitudes. Okay, high altitudes. Then anemic hypoxia. Anemic hypoxia, the problem is with the hemoglobin. There is some problem with the hemoglobin, maybe methemoglobinemia, okay, or carbon monoxide poisoning. So anemic hypoxia is going to be seen in methemoglobinemia or carbon monoxide poisoning. Okay, carbon monoxide poisoning. The patient is going to have anemic hypoxia where the oxygen is Continue. Okay. Okay, the lungs are not going to be compliant. The lungs are going to get collapsed. So tell me, in a baby who is a preterm baby, the baby is going. Okay, start, Jena. Clear, huh? Okay, guys. Okay, guys, let's continue. Again, there is an issue. That's why I have told you, when the surfactant is not there, the surface tension is going to increase. When the surface tension is going to increase, what will happen to the compliance? The compliance is going to be reduced. So again, I am repeating, as there is a disturbance. Again, I am going to repeat the same thing. Say in a preterm baby, surfactant is not there. When surfactant is not there, the surface tension in the lungs will go up. When the surface tension in the lungs is increasing, means the lungs are collapsing. When the lungs are collapsing, what will happen to the compliance nature of the lung? The compliance nature, the stretchability of the lung will decrease. Okay, so this is the answer. Next, you can see here, this is the flow volume loop. Okay, sorry, this is a pressure volume loop. Now in this pressure volume loop, it's very clear that lung compliance is less. Okay, the lung compliance is less during the phase of inspiration. During the phase of inspiration, the lung compliance is less, and during the phase of expiration, the lung compliance is more. You can see the two lines, you can see the two graphs. Okay, during the phase of inspiration, look, the slope, the curve is having less slope, and during the phase of expiration, the compliance is going to be more, the slope is more. Okay, the slope is more. So this is the during expiration, this is during inspiration. So the compliance of the lung during inspiration and expiration, is it same? Your lungs are having some compliance property. Is it going to be same during inspiration and expiration? No, the compliance is not same during inspiration and expiration. There is a difference in the compliance. there is a difference in the trajectories of the curve. Okay, so why there is a difference? Look, the difference in the trajectory between inspiratory curve and expiratory curve in the compliance graph is due to, it is due to continue here. Clear again? When the partial pressure of carbon dioxide increases, or when the partial pressure of oxygen decreases, that is the hypoxic conditions, or hypercapnia conditions, exercising conditions, are the conditions whenever the temperature increases. Okay, temperature increases in the body. When temperature increases, you know, whenever you are doing exercise, the basal metabolic rate will be more, the temperature will be more, or when the H plus production is more, or the pH is less. Okay, in all these conditions like exercising conditions, PCO2 level increases, hypoxic conditions, temperature is more, there is acidosis, okay, low pH, or whenever you are doing exercise or whenever there is acidosis in the body, what will be produced in the RBCs? 2,3-bis-phosphoglycerate or 2,3-diphosphoglycerate. Now, all these conditions, whenever you are having this environment in the body, exercising environment in the body, the patient is going to have right shift. But in the question, I am asking about the left shift. When you will see this left shift means less oxygen delivery to the tissues. Less oxygen to tissues. Less oxygen to the tissues. In which conditions? Alkalosis. Okay, alkalosis. When the PCO2 value decreases, when the pH increases, when the H plus concentration decreases, or in the presence of fetal hemoglobin, it shows left shift. Less oxygen will be delivered to the tissue. Fetal hemoglobin have high affinity for the oxygen. It's not going to release the oxygen easily. Okay, so now tell me, left shift is going to be seen in which condition? Alkalosis conditions, high pH, less H plus, alkalosis conditions may there is going to be left shift. Next, in the recent exam, they have asked about the spirometry. You have to know about the spirometry. Identify the marked area in the spirometry graph. Now, this is the marked area. Now, what do you think this marked area? See, you know, this is the normal tidal volume. This is representing the tidal volume. These curves are representing the tidal volume. Now, from here to here, what is this? This is the extra air that you can take into your lungs. With effort, you can take some extra air into your lungs. This is called as inspiratory reserve volume. Okay, again, this is the tidal volume. But with extra effort, you can take this air out of the lungs. This is expiratory reserve volume. So now I am pointing an arrow which is including tidal volume, inspiratory reserve volume and expiratory reserve volume. If you add these three volumes, that is inspiratory reserve volume, tidal volume and expiratory reserve volume. If you add these three volumes, you are going to get a capacity. You are going to get a capacity. What is the capacity? That is vital capacity. It's not here. That is vital capacity. Okay, vital capacity. If I ask you, what is this marked area? Okay, what is this marked area from here to here? From here to here. Now, you know this is an area of expiratory reserve volume and this is an area of residual volume. Whatever you do, some air will never come out of the lungs. Some air is always present in the lungs. Almost somewhere around 1.2 to 1.3 liters, 1200 to 1300 ml of air is always present in the lungs. It will never come out. So this area which I am highlighting from here to here, it includes expiratory reserve volume and residual volume. So if you add these two volumes, that's going to give you functional residual capacity. Okay, that's going to give you functional residual capacity. Okay, so you have to know about the spirometry also. Spirometry curves are very important. Before going to the exam, know each and every volume and each and every capacity. Okay, next, let's discuss about V by Q ratios, ventilation by perfusion ratios. In a normal lung, how much ventilation and how much perfusion? If you take a ratio, in a normal lung, the ventilation perfusion ratio is going to be 0.8. But if they specifically ask you about the apex of the lung, in the apex of the lung, the ventilation perfusion ratio is 3.2, the value. In the base of the lung, the ventilation perfusion value is 0.6. 0.6. In certain conditions, the ventilation perfusion ratio is going to be infinity. And in certain conditions, ventilation perfusion ratio is going to be 0. In which condition ventilation perfusion ratio is infinity? In which conditions? Two conditions. One is pulmonary embolism and anatomical dead space. Anatomical dead space. In these two areas, okay, one is anatomical dead space, and in a condition called as a pulmonary embolism, if you measure the ventilation perfusion ratio of the lung, it will be infinity. And in which condition the ventilation perfusion ratio is going to become 0? In a condition called as foreign body obstruction. Foreign body obstruction to the respiratory tract or airway compression. Okay, foreign body obstruction, airway compression or atelectasis. Atelectasis. So foreign body obstruction, FBO means foreign body obstruction, you anyway know it. Airway compression and atelectasis. These are the conditions in which the ventilation perfusion ratio is going to be 0. So now what is the question? Ventilation perfusion ratio is infinity holds true. You know, infinity is going to be seen in pulmonary embolism and anatomical dead space. Okay, so with this, the important topics which you should know in respiratory are also completed. Now let's discuss about the gastrointestinal physiology. Actually, the weightage for the gastrointestinal physiology is going to be relatively less when compared to the other systems. So let's see. Which of the following subsequent pairs are incorrectly matched? See, gastrin hormone is produced by G cells in the stomach. True. It's a true statement. Secretin is produced by the S cells of duodenum. True. Cholecystokinin is produced by the I cells. Cholecystokinin is produced by the I cells of the duodenum. True. But motilin is produced by Mo cells, not the M cells. Motilin is produced by Mo cells. So this is the answer. Okay, that's the answer. Incorrectly matched, right? So incorrectly matched. Who is incorrectly matched? Motilin is produced by the Mo cells, not the M cells. You know, motilin is going to help in the GIT motility. Which type of GIT motility? Migratory motor complex. Okay, during fasting state. See, whenever you are doing fasting, see, I haven't ate anything from the morning, so I am doing fasting. Okay, let's say. Now, motilin is going to cause the contractions in the GIT to clean the GIT. Motilin will cause the contractions even during fasting. That is called as a migratory motor complex. Okay. This motilin receptor, one more thing, motilin receptor can be stimulated with the help of a drug called as erythromycin. Okay. Next most important topic which you should know in the gastrointestinal physiology is peristalsis and segmentation. See, what is the type of GIT motility shown in the image below? In this image, I am showing you the proximal segment is contracting and the food bolus is gradually moving forward. Okay, towards the rectum. The food is moving towards the rectum. The food is propulsing. Okay, there is a propulsion of the food. So, what is this type of motility? So, this is called as a peristalsis. Okay, this is called as peristalsis. This is not segmentation. This is not migratory motor complex. So, the proximal segment is contracting and the food is not going back. There is no regurgitation back. Okay. So, what they will ask in your exam? This proximal segment is contracting, right? Who is going to contract this proximal segment? It is because of acetylcholine. Acetylcholine and substance P is going to contract the proximal segment, and who is going to cause the dilation of this distal segment? The distal segment is getting dilated, right? This dilation is because of nitric oxide and vasoactive intestinal peptide. Okay, so you have to know what is peristalsis and what is segmentation before going to the exam. So peristalsis I have explained here clearly. The proximal segment will contract and the distal segment will relax. So the food is going to go forward. The food is going to go forward. Next. Following a complete ileal resection, okay, complete ileal resection, partial jejunal resection. Means here the complete ileum is gone. We have removed the complete ileum in the patient. If complete ileum if we remove, there will be definitely certain substances will not going to be affected, absorbed. Okay, certain substances are not going to be absorbed. Which substances are not going to be absorbed if the patient is having complete ileal resection? You know, ileum is a place where the vitamin B12 will be absorbed. So this patient is going to have vitamin B12 deficiency. See, iron in Fe2+ form, ferrous form, iron will be absorbed in duodenum. Vitamin B9, okay, vitamin B9 is absorbed in jejunum. And vitamin B12 is absorbed in ileum. Along with intrinsic factor. Okay, only in the presence of intrinsic factor, the vitamin B12 is going to be absorbed in the ileum. Okay, next. What is the transporter for iron into the enterocytes? See, this is the duodenum. Let's say this is the duodenum. Duodenum, it is having which cells? These are the enterocytes. Now, these enterocytes are having special transporters. They are having transporters through which the iron will be absorbed into the cell. So, what is the name of this transporter? The name of this transporter is called as a DMT1. With the help of a transporter called as a DMT1, the iron is absorbed into the enterocytes. Okay, and we have to know what are the substances which are going to increase the iron absorption and decrease the iron absorption, which is a recent question. Continue. So, who increases the iron absorption? Acid and vitamin C. Acid and vitamin C increases the iron absorption. Okay, milk decreases the iron absorption, tea decreases the iron absorption, antacids decrease the iron absorption, phytates, tannates decreases the iron absorption. Okay, so these are the important things which I want you to know in the gastrointestinal physiology. Next, let's go to the renal physiology. In renal physiology, see, efferent arteriolar constriction in the efferent arteriole. Okay, you know, there is afferent arteriole, glomerular capillaries, and efferent arteriole. When the efferent arteriole is constricted, what happened to the GFR? Okay, you have to know these changes. Anyway, I will give you this table. What will happen to the GFR? If the efferent arteriole is constricted, initially GFR increases. Later GFR decreases. Okay, true. If the efferent arteriole is constricted, what will happen to the glomerular capillary? What will happen in the glomerular capillary? The hydrostatic pressure, also the oncotic pressure, both will increase. The hydrostatic pressure and the oncotic pressure in the glomerular capillary increases. GFR initially increases, later decreases. If you constrict the efferent arteriole, you have blocked the way. So the amount of blood that will come to the kidney, okay, is also going to decrease. Okay, renal blood flow also decreases. So look at here, efferent arteriole, if you constrict it with the help of angiotensin II, what is happening to renal blood flow? Renal blood flow decreases. What is happening to hydrostatic pressure? Increases. What will happen to oncotic pressure? Decreases. Sorry, increases. So what is the answer here? Except, right? Decrease in oncotic pressure. No, oncotic pressure will increase. Hydrostatic pressure will increase. So both hydrostatic pressure and oncotic pressure will increase, not decrease. Okay. Next, concentration of which of the following substance decreases in the PCT? In the proximal convoluted tubule, which substance concentration decreases? Remember, sodium concentration, chloride concentration will not decrease. Glucose concentration decreases. Amino acid concentration decreases because 100% glucose will be reabsorbed. 100% amino acids are going to be reabsorbed. So the concentration wise I am talking. The concentration of glucose and amino acids decreases in the PCT, not the sodium chloride. Okay. Next, which of the following statement is true regarding the cystometrogram? See, this is the cystometrogram. You know, the pressure changes in the bladder. The pressure in the bladder is increasing, constant, again increasing. Look, guys, they're asking the true statement, right? Segment number 1 is due to residual urine. Segment number 2 is due to Laplace law. See, the most important thing is this segment number 2. See, during this segment number 2, the pressure in the bladder is not increasing. The pressure in the bladder is not increasing. The pressure in the bladder is almost maintained constant. Why the pressure in the bladder is not increasing? Is because of the Laplace law. It's explained by the Laplace law. Because of this Laplace law, the pressure in the bladder is not going to rise. It's almost maintained constant for certain time. So what you will ask in your exam? The phase 2. Phase 2, or sometimes they can say phase 1b also. This phase 2 is explained by Laplace law. This phase 2, it indicates bladder compliance. The bladder is stretching. Actually, during this phase 2, the bladder is stretching. So it is compliance, or we can say plasticity. Plasticity of bladder. What is happening in the phase 2? It's a plasticity of the bladder, the stretchability of the bladder, explained by the law of Laplace. The pressure is maintained constant. This is a true statement. Okay. Next, identify the correct matched pair of substances with their renal clearance. Very, very important. Look here. There is a substance. Okay, actually there are 4 substances: A, B, C, and D. A substance, it is 100% filtered. 100% filtered into the woman's capsule. But this substance A is becoming 0. From 100 to, it is becoming 0 within the proximal convoluted tubule itself. In the beginning of the proximal convoluted tubule itself, the substance concentration is becoming 0. What is that substance? Glucose. Then there is the substance B. Almost its concentration is also becoming 0. What is the substance? It's the bicarbonate. There is the substance C, which is 100% filtered, but its concentration is maintained constantly in the proximal convoluted tubule, in the distal convoluted tubule, in the urine. Its concentration is maintained constant. It is still 100%. 100% is there in the pre-CT, 100% is there in the DCT, 100% is there in the urine. which means the substance is freely filtered, but it is never reabsorbed. What is the substance? Inulin. Inulin freely filtered, but not reabsorbed. But there is the substance D. It is just 100% filtered. But if you check in the urine, its concentration is somewhere around, let's say, 200. Means its concentration is increased. How? It is increased. So the substance D, it's not only filtered, it's not only just filtered, but it is also secreted. Okay, it's not only just filtered, it's also actively secreted. So what is the substance D? This is para-aminohippuric acid. So you have to know para-aminohippuric acid is freely filtered, never reabsorbed, but secreted. Inulin, if I am talking about inulin, inulin is freely filtered, never reabsorbed, never secreted. So here the option is B. A is glucose, B is bicarbonate, C is inulin, D is para-aminohippuric acid. Okay. Now the protein in the glomerular basement membrane, you know glomerular basement membrane is having negative charge. That negative charge of the glomerular basement membrane is due to the presence of which protein? It is due to heparan sulfate. Due to the presence of this heparan sulfate, the glomerular basement membrane is going to have negative charge. What is the function of tubuloglomerular feedback? There is something called the tubuloglomerular feedback, which is given by the macula densa. This tubuloglomerular feedback, what is the role? What is the role of tubuloglomerular feedback? Why? This tubuloglomerular feedback is to regulate the GFR, is to maintain the GFR in the normal range. Okay, so who gives the tubuloglomerular feedback? Macula densa. Where is macula densa present? Ascending limb of loop of membrane. Okay. Next, antidiuretic hormone, also called as vasopressin, acts through which aquaporin channel? Now look at here, guys. This antidiuretic hormone. Look at here. This antidiuretic hormone, it is acting on its receptor. When it is acting on its receptor, now water reabsorption is happening. See, water is getting reabsorbed into the cell with the help of which channels? Aquaporin 2 channels. So when the antidiuretic hormone is acting on the cell, when the ADH is acting on the cell with the help of aquaporin 2 channels, water will be reabsorbed into the cell. What will be? Aquaporin 2 channels. Antidiuretic hormone acts through which aquaporin channel? Aquaporin 2. What is the receptor of antidiuretic hormone? On the collecting ducts. On which receptor it will act? Antidiuretic hormone acts on V2 receptor. When you stimulate this V2 receptor, when you stimulate the V2 receptor, look, when you stimulate this receptor, what will happen? Intracellular levels of 𝗂𝗵 will increase. That's a question. V2 receptor activation is going to increase the intracellular levels of 𝗂𝗵. That increase in the intracellular levels of 𝗂𝗵 is going to produce this aquaporin 2 channels, which will help in the absorption of water. Next, kidney responds to shock by. When the patient is having shock. Shock means what? The patient's BP is crashing. Okay, the patient's BP is crashing. The perfusion to the tissues is decreasing. Tell me, at this time, you have to produce more urine or less urine? At this time, you have to conserve the fluids. You have to conserve the body fluids. This is not the time to excrete the water. So, whenever there is a shock, there should be decrease in GFR. How can you decrease the GFR? Afferent arteriolar constriction. So, how will we respond to the shock? By increasing the afferent arteriolar resistance. When afferent arterial resistance is increased, that's going to decrease the GFR. Okay. A patient has a blood glucose level of 200 milligrams per deciliter. Okay, this much glucose is there in his plasma. And what is his GFR? 90 ml per minute. His GFR is 90 ml per minute. What is the amount of glucose excreted if the transport maximum of this patient? Okay, the transport maximum value for the glucose is just 150 milligrams per minute. So, how to understand? Look here, guys. This is an nephron. Let's imagine this is a nephron. Okay. How much glucose is there in his plasma? In his plasma, there is 200 milligrams per deciliter. 200 milligrams per deciliter. Which means 200 milligrams of glucose is present in 100 ml of blood. So in each ml, in 1 ml, how much glucose is there? 2 milligrams glucose is there. Tell me what is his GFR? His GFR is 90 ml. So 90 ml is getting filtered every minute. In this 90 ml, how much glucose is there? Every ml may 2 milligrams. So 90 into 2. So 180 milligrams of glucose is getting filtered every minute. 180 milligrams of glucose is getting filtered into all his nephrons every minute. Out of this 180, how much he can maximally reabsorb? 150. He can reabsorb 150 every minute. That's his maximum capacity. If he reabsorbs 150, how much is going to be lost in the urine? Okay. So 30 milligrams of glucose is going to be lost in the urine. So such kind of questions can also show up in your exam. Okay. After this, now let's discuss the nervous system. Important things that you should know in the nerve physiology. Lesion of the medial limb meniscus. Anyway, you know this from your anatomy also. Medial limb meniscus, dorsal column, medial limb meniscal pathway carries the advanced sensation. If there is the damage to the medial limb meniscus in the pons, tell me, the advanced sensations are going to be lost on the opposite side of the body. Because you know, advanced sensations travels on the same side of the spinal cord, but they crosses in the medulla and travels as medial limb meniscus. So medial limb meniscus is carrying the advanced sensations from the opposite side of the body. So tell me, the patient is going to lose the proprioception advanced sensation. Okay, loss of tactile and proprioceptive sensation on the opposite side of the body. Okay, loss of fine touch. Tactile is a fine touch and a proprioception on the opposite side of the body. Okay. Next, a lady presented with a vascular injury to the inferior frontal gyrus. The moment you hear about the inferior frontal gyrus, you know, in the inferior frontal gyrus, there is an area called as the Broca's area. Broca's area. When the Broca's area is damaged, the patient is going to have the difficulty in the speech. Motor speech area is affected. So tell me, the vascular injury to the inferior frontal gyrus, which of the functional area is most likely affected? It's a motor speech area, or you can say Broca's area, Brodmann's area number 44. Brodmann's area number 44. Broca's area is affected. There will be aphasia. Okay, he can't speak properly. Broken speech is going to be there. Expressive aphasia is going to be there. Okay. Next, a patient met with a road traffic accident developed a cervical spine injury. Okay, he's having a problem with the cervical spine. The fractured fragment have pierced the lateral aspect of the dorsal column tract. See, very simple. Look at here. See, this is your spinal cord. Now, look here. In the dorsal column, you know, there is fasciculus gracilis in the medial side, and there is fasciculus cuneatus on the lateral side. Now, what happened in this patient, in the cervical spine, the cervical area of the spinal cord, the lateral area, okay, the fractured fragment have damaged this lateral area of the dorsal column. If the lateral area of the dorsal column is affected, means which tract is affected? Fasciculus cuneatus is affected. Now, what is fasciculus cuneatus carrying? Fasciculus cuneatus carries the advanced sensations from the upper limb. So the patient is going to have loss of advanced sensations in the upper limb on the same side, because dorsal column sensations do not cross in the spinal cord, they cross at the medulla. Okay, so there is absence of ipsilateral, same side, ipsilateral arm proprioception, because fasciculus cuneatus is affected. Okay, fasciculus gracilis is affected, there will be loss of proprioception function, vibratory sensation from the lower limbs. Okay, next, Brown-Séquard syndrome is characterized by, you know, Brown-Séquard syndrome means hemisection of the spinal cord. Half of the spinal cord is damaged. Okay, half of the spinal cord is damaged. If half of the spinal cord is damaged at a particular segment, the patient is going to lose advanced sensations on the same side of the lesion. For example, let's say this is right side, this is left side. Now the lesion is on which side? The lesion is on the left side. Now in this patient, there is loss of advanced sensations on the left side and loss of primitive sensations on the right side. So tell me, in Brown-Séquard syndrome, there is loss of advanced sensations on the same side of the lesion and loss of primitive sensations like touch, pain, temperature, pressure on the opposite side of the lesion. So what's the answer? In Brown-Séquard syndrome, there is pain and temperature loss on the opposite side. True. Pain and temperature are the primitive sensations. So they are lost on the opposite side. Advanced sensations should be lost on the same side. Okay. Next, true statement regarding the nerve action potential curve. Nerve action potential curve. What is the true statement? See, threshold point is at A. Okay, they are talking about threshold point is at A. See, this A here, this is the A, let's say this the A is the resting membrane potential. Resting membrane potential. Okay. So this is not the correct thing. At point E, nerve is more excitable. At point E, nerve is more excitable. Where is the point E? See, point E is the hyperpolarization phase. Point E is the phase of hyperpolarization. Hyperpolarization means nerve is more inactive. Nerve is not more excitable. Nerve is more inactive. This is wrong. This is wrong. Point number C to D. Okay. Point number C to D is due to opening of sodium and closing of potassium channels. Let's say D. Let's keep D here. Okay. Let's say keep D here. So C to D. C to D is the phase of repolarization, you know it, repolarization. Repolarization means a potassium channel should be open, potassium should be going out. So this is wrong. Point number C to D is due to opening of sodium. No, it is due to opening of potassium. So this is also wrong statement. All these three are wrong. Point number B to D is the refractory period. Absolutely, yes. Point number B to D from here to here. Let's say point number B to point number D. So this phase which I am highlighting, the depolarization and also repolarization. So this phase is called as refractory period where the nerve is completely inactive. It's completely inactive. It is not going to throw one more action potential. It's not going to generate one more action potential. How hard the stimulus you give. So this is called as the resting period or refractory period. Point number B to D. Okay. Next, stimulus above the threshold intensity leads to constant amplitude of action potential. This is known as, guys, look at here. You are giving little stimulus. You are increasing the stimulus. You are increasing more stimulus. Okay. How much ever you increase the stimulus, the action potential, whatever the action potential, whatever the voltage that is generated during the depolarization, the height of action potential is always same. It doesn't matter, like, say if you give more stimulus, more action potential, less stimulus, less action potential. No, it's not like that. Doesn't matter what is the stimulus. Always the amplitude, the height of the action potential is a constant. This is called as law. All or none law. This is called as all or none law. Okay. Always the amplitude, the height of the action potential is constant regardless of the stimulus. All or none law. Next, a 65-year-old man suffered from stroke. Okay. He now present with the involuntary violent flinging movements. The moment you hear about the word flinging movements, abnormal movements, flinging movements of the limbs, on the one side, what is the most likely site of the lesion? See, in this patient, I can say the basal ganglia, the structure of the basal ganglia is affected. That's why he is having involuntary movements. Which structure is affected? Flinging movements. The moment you see the word flinging movements or railing movements, sudden flinging movements, you have to think about this patient is having hemibalisms or hemibalismus. In hemibalismus, subthalamic nucleus is affected. So look here, in hemibalismus, in a patient who is having hemibalismus, subthalamic nucleus is affected. The patient is going to have railing or flinging movements. Okay. If the caudate nucleus is damaged, the patient is going to develop chorea. Okay, chorea. If globus pallidus is affected, the patient is going to develop 𝗏etosis. 𝗏etosis is a writhing movement. 𝗏etosis is a writhing movement. Chorea is a flicking movement, not flinging, flicking movement. Flinging movement is hemibalismus. Just now I have discussed. Flinging movement is hemibalismus. The structure that is affected is subthalamic nucleus. Okay. Now vomiting center. Where is vomiting center present? Vomiting center is present in an area called as area postrema, which is outside the blood-brain barrier. It is outside the blood-brain barrier. It's present in the medulla, near the medulla. Area postrema, it is outside the blood-brain barrier. It is your vomiting center. Okay. Nucleus of tractus solitarius, it is involved in sensing taste information. Okay, taste information. Here, I want you to know one is rewarding center. Rewarding center. Okay, who is the rewarding center in your brain? Okay, our rewarding center is ventral tegmental area. Okay, ventral tegmental area is the rewarding center. What is the addiction center? Addiction center. It is a nucleus accumbens. Nucleus accumbens is the addiction center. Okay, rewarding center is the ventral tegmental area. Vomiting center is the area postrema. It's outside the blood-brain barrier. Which structures are outside the blood-brain barrier? Which structures are not covered by the blood-brain barrier? Area postrema, posterior pituitary, subfornical organ, organum vasculosum. These are the four areas. These are four areas which are not covered by the blood-brain barrier. Okay, they have a direct contact with the blood. They can sense the chemicals in the blood. Okay, so area postrema, it is your vomiting center. Which of the following has the least conduction velocity? Which neurons has the least conduction velocity for the electrical impulse? Look at here, guys. Okay, this 𝗏𝗏𝗃 classification. According to the 𝗏𝗏𝗃 classification, neurons are classified into A type of fiber, B type of fiber, and C type of fiber. A type of fiber are highly myelinated. A fibers are highly myelinated fibers, which are having highest conduction velocity. The C type of fibers, look here, the C type of fibers are having no myelination. They are unmyelinated fibers. C fibers are having no myelination, unmyelinated fibers. So the velocity of impulse conduction is also going to be very less. So tell me which neurons have least conduction velocity? C fibers are having least conduction velocity. C fibers are unmyelinated. Where are the C type of neurons present? C type of neurons are present in postganglionic sympathetic nerves. In the postganglionic sympathetic nerves, you have C type of fibers. So the C fibers are having least conduction velocity. The postganglionic sympathetic fibers have least conduction velocity. A fibers will have fast conduction velocity. Especially the point which I want you to know for your exam is this: the A fibers are further classified into, according to 𝗏𝗏𝗃 classification, A fibers are further classified into A delta fibers. A delta fibers carry fast pain, but C fibers carry slow pain. Fast pain is carried by A delta fibers, slow pain is carried by C fibers. Okay, that's the point which I want you to know for your exam. Next, a person is sleeping with arm under his head. When you sleep with arm under your head, the head is going to put some pressure on your hand. Okay, for example, you are sleeping with like some person, and the person is like, for example, the wife is sleeping on the hand. Okay, now what will happen? That's going to exert the pressure on the nerves. When you apply the pressure, which neurons will be first affected? With pressure, which type of fiber will be first affected? A fiber, B fiber, or C fiber? Which fibers are highly sensitive to pressure? It's the A fibers, especially 𝗵𝗄 fibers. So A fibers are first affected. Okay, that's why in the morning it will be difficult for you to to use your hand, because for muscle contraction, see, for muscle contraction, somatic motor neurons are 𝗵𝗄. 𝗵𝗄 are the motor neurons. So with the pressure, A fiber will be affected. A fiber will be affected. So it will be difficult. Paralysis will be there. It will be difficult for you to use your arm. The answer is, sir, A fibers are more sensitive to pressure than C fibers. Okay, that's why in the morning, because of the damage to the A fibers, it is hard for you to use the arm. Okay. Next, identify the type of transport shown in the image below. In this image, it's very clear that with the help of this carrier protein, with the help of a carrier protein or carrier channel, the substances are moving from high concentration to low concentration. Substances are moving from, yes, high concentration to low concentration. But a protein is helping in this process. So this is diffusion, but facilitated diffusion. This is not simple diffusion. This is facilitated diffusion because proteins are involved, protein channels are involved. Wherever you see the word 𝗏𝗏𝗃, okay, GF, girlfriend, something like that, right? So wherever you see the word 𝗏𝗏𝗃, glucose transporter type 1, 2, 3, 4, 5, 6, 7, 8, doesn't matter. All the glucose transporters, wherever you see, they're all examples of facilitated diffusion. They're all examples of facilitated diffusion. Wherever you see the word ATPase, sodium potassium ATPase, proton ATPase or proton pump, ATPases are pumps, calcium pump, calcium ATPase, they are all example of primary active transport. Wherever you see the word co-transporters, symporters, co-transporters or symporters are SGLTs, SGLT1 or SGLT2, that is sodium glucose, the co-transporter type 1, type 2. Wherever you see the word, they are all examples of secondary active transport. So tell me, 𝗏𝗏𝗃s are example of facilitated diffusion, pumps and ATPases are example of primary active transport, secondary active transport examples are co-transporters, symporters are SGLTs. Glucose is a transporter along with sodium. Remember, glucose is a transporter along with sodium. SGLT, sodium glucose co-transporter. Okay. Next, glucose uptake into the adipocytes and skeletal muscle. I have told you, in the presence of insulin, adipocytes and skeletal muscles will use the glucose, will take the glucose with the help of a glucose transporter type 4. Wherever you see the word glucose transporters, they are all examples of facilitated diffusion, GF. So glucose uptake by the adipocytes and skeletal muscles is an example of facilitated diffusion. All glucose transporters example of facilitated diffusion. Adipocytes and skeletal muscles have which type of glut? GLUT4. GLUT4 is which hormone dependent? Insulin dependent. Okay. Where is SGLT1 present? SGLT1, it is present in your intestines. SGLT2, I have told you, wherever you see the word SGLT, example of secondary active transport. Glucose is absorbed along with the sodium. Okay, glucose is absorbed along with sodium. SGLT1 is present in your intestines. SGLT2 is present in your nephrons, PCT. Okay. Now look at this question. Organize the listed bands in a sarcomere from periphery to center. See, in a sarcomere, let's say this is the sarcomere. Sarcomere is an area which is bounded between two Z lines. Here is one Z line, here is the other Z line. So always in the periphery there is Z line. Always in the center there is M line. Okay, here also say there is M line. In the periphery may Z, in the middle, in the center, in the middle there is M. Z, M. Now look at here, in the sarcomere, there is an area, look, there is an area where only actin filaments are present. These red color filaments are actin filaments. So this area is called as the I band, isotropic band. Okay, this area is I band. Next to I band, there is an area where there is actin, myosin. So this is called as A band, anisotropic band. Okay, there is anisotropic band. So tell me, there is Z line, I band, A band, M line. Okay, or you can say there is one more area. Let's see this area. There is one more area where only myosin is present. Myosin is a heavy chain, right? Actin is light. Myosin is heavy. So myosin, this area is called as H zone. There is H zone. So what I'm trying to put into your mind is, guys, in a sarcomere, always in the periphery there is Z. Later there is I band. Later there is A band. In the A band, see, in the A band, from here to here there is A band. You know it. Both actin present, myosin. This is A band. In the A band, in the center, there is H zone. In the H zone, there is M line. So you have to say from periphery to center. Z line, I band, A band, H zone, M line. Okay. So what is the answer? they are asking from periphery to center, right? So who should be in the periphery? Always Z should be in the periphery. And who should be in the center? M should be in the center. So option should start with Z and end with M. So it should start with A and B. Where is that? Here, A and B. So this is the answer. Okay, simple as that. Okay, you have to know the order. Again, Z line, I band, A band. In the A band there is H zone. In the H zone there is M line. There is M line. Okay. Next, which of the following is not a molecular motor? See, inside your cells, there are certain proteins called as molecular motors, which will help in the transport of substances from one end to the other end. There are three important molecular motors. One is dynein, kinesin, and myosin. Dynein, kinesin, and myosin. These three molecules, they will help in the intracellular transport, but not the actin. This is not a molecular motor. Dynein helps in what kind of transport? Dynein helps in something called as a retrograde transport. Retrograde transport. Kinesin helps in anterograde transport. So how to remember? Doctor. So dynein helps in retrograde transport. Okay. So these are the three important molecular motors: dynein, kinesin, and myosin, which is a recent previous year question. Okay. Absolute refractory period is due to. Okay. Guys, I have already told you there is a refractory period. See, you know this is the resting membrane potential. In a nerve action potential, there is resting membrane potential. After that, there is a depolarization, repolarization, hyperpolarization. You know it. Now, look at this period. The period which I am highlighting here, see, from here to here. Starting from the depolarization to here. So, during this period, whatever you do to the neuron, it is not going to produce a new action potential. It will never produce a new action potential. So, this time period is called as absolute refractory period. So, during this particular time, whatever the hell you do, it's not going to produce one more action potential. So, that is called as absolute refractory period. And after that time, so there is this relative refractory period. Okay, relative refractory period means a normal stimulus will not produce an action potential. A more stimulus, little bit more powerful stimulus will produce an action potential. Okay, so there is absolute refractory period and relative refractory period. Two periods are there. Now, question is, what is happening during the absolute refractory period? Why during the absolute refractory period? Why there is no new action potential generation? Because the inactivation gates of the sodium channels, of the neurons, they are actually closed. So due to the closure of inactive gates of the sodium channels, okay, see, actually there is an activation gate and there is an inactivation gate. During the phase of absolute refractory period, the inactivation gate is actually closed. Because the inactivation gate is closed, the sodium can't come into the cell. Without sodium, there is no depolarization, no action potential. So, if someone asks you during absolute refractory period, why there is no action potential, why you can't produce a new action potential, is because the inactivation gates of the voltage gated sodium channels are closed. That's why you cannot produce a new action potential. Okay, so with this, we have done all the important topics which are needed for the exam. Okay, highly anticipated topics. Action potentials, very, very important for your exam. Cystometrogram, spirometry graphs, heart sounds and murmurs. Okay, the transport, facilitated diffusions, primary active transport, secondary active transport, all the topics, whatever I have discussed here, are super high yielding. Hope most of the MCQs will be coming from this session. Okay, having said that, hope the session is going to be helpful for you guys. All the best for your upcoming FMGE exam. Okay, these days, whatever are left, okay, try to give your best, try to revise as much as possible, try to go through the PYQs, do revision. Okay, the main thing what you have to do all this period is revision, doing as many MCQs as possible, mainly previous year questions. Okay, mainly PYQs. Okay, having said that, all the best guys, all the best for your exam. See you in the next session. Thank you.